what you need to look at are what are the surfaces that are the highest risk of transmission, what we call high touch surfaces. And then the general education that my children were well versed in, because they had me as a father, is we never touch our nose, our eyes, or our mouth with hands that have not been cleaned.
Public health. It's on everyone's mind these days, from hand washing to emerging pathogens. Welcome to Transmission Control, an infection prevention podcast focused on your appetite for trailblazing thought, discussion, and innovations that will help you make informed decisions. Each episode, we speak with public health experts and safety champions from across the globe as they share their experiences, passion, and opinions. From investigative journalism to medical publications, we tackle real-world barriers to halting the spread of disease. Whether you are tuning in for education, inspiration, or to hear the stories that need to be told, thank you for joining us. And now, get ready to blast off with your weekly injection of insight on transmission control.
This week on Transmission Control, we speak with Jim Gauthier, MLT CIC, Senior Clinical Advisor of Infection Prevention at Diversey. And Larry, we're going to be talking about considerations for primary care offices or primary care practices. So we already had an episode where we talked about long-term care and implications in that environment. And we're going to be talking to Jim. I'm even going to share some of my own personal experience of going to see my doctor throughout the pandemic. But obviously, the world has changed. The general public is much more aware of some of these considerations. And I'd say there were quite a few that just didn't even want to go see their doctor or their primary care physician and delayed appointments just on their wellness checks throughout especially the early stages of the pandemic. So I think awareness in those physicians' offices, not only just ways to help prevent transmission, one of our favorite words here at Transmission Control, to prevent transmission, but also understanding there's still a vulnerable population that's going into those settings and that, the appropriate cleaning and care to prevent that spread is really important. And I'm not sure that we're always talking about that. So much of our focus in this industry is often in the acute setting.
Yeah, so I'm going to ask Jim some questions about, you're kind of alluding to it, of the unconscious cues that when we walk into a physician's office, as opposed to an acute care setting. We did notice that patients were canceling their appointments to see their dentist and to see their primary care physicians. And I think those type of practitioners might want to be sensitive to bringing back the patients and making them feel comfortable. And that might be, for example, the patients in the exam room or in the waiting room actually watching staff wipe down surfaces, the frequently touched surfaces, and to wear the personal protective equipment properly, maybe to have some checklists that give the patient a comfort level. I think this is some really important points that give a sense of satisfaction and comfort and safety for those who have scheduled appointments in this physician office setting. I would like to talk also, Jim, about differences between contact precautions, droplet precautions, and airborne precautions. And hopefully we can get into a little bit of a discussion about COVID-19, where at first we thought it was transmitted exclusively by the droplet route, and maybe even sometimes by direct contact. I'm interested in hearing what Jim has to say about the possibility, as some data are suggesting, that it may also be transmitted by airborne routes, and therefore what different practices would we implement for airborne routes in comparison to and in contrast to droplet routes.
All right. Jim will be telling us about his diverse experience in many different settings in healthcare. I think you'll find his perspective quite engaging. We'll be right back with Jim Gauthier, MLT CIC, Senior Clinical Advisor of Infection Prevention at Diversey. I'm Justin Poulin.
And I'm Dr. Lawrence Muscarella.
From 17 Studios, let's get into it. This is Transmission Control.
Joining us now is Jim Gauthier, MLT CIC, Senior Clinical Advisor for Infection Prevention at Diversey. And Jim, we saw a post that you put out on LinkedIn talking about physicians' offices, and really don't let your guard down was the title. And so I want to point all of our listeners back in that direction. There's a large audience that listens to our show that is very much in the acute setting, in the hospital setting, but we've done interviews for long-term care, and really in this whole new world of the pandemic, I think the general public has started to pick up on some of our shows just because they're so much more aware of infection control concerns than they ever have been prior to 18 months ago. So, Jim, this one really stuck out to us, and I thought it was an important topic to have you join us today. So thanks so much for coming on this episode of Transmission Control.
I'm really happy to be here. I'm glad I got the invite.
So, Jim, why don't you just talk a little bit about your background? I mean, obviously you got some certifications and a lot of experience in the industry. Why don't you introduce yourself to the audience?
Sure. So my main background, you mentioned my letters. So the MLT is by training. I'm a medical laboratory technologist, and most of my work experience as a lab tech was in hospital laboratories, working in microbiology. So I have an intimate knowledge of microorganisms. I have done from basic bacteriology, so growing bugs that come in on swabs to help diagnose strep throat, to working with fecal material to try to diagnose why you've got diarrhea, including looking for parasites. That's a whole other aspect that I managed to work into. I've done a tiny bit of virology in the laboratory. I've done blood bank, took call, coming in the middle of the night to try to find out what had happened to someone and get them healed up a little bit from the lab perspective. But through that, I also discovered in my background, I am a community theater actor. I love being up in front of people and talking. I think I have a good sense of humor. And I found that talking to people about microbiology really tied into infection prevention and control. And I could talk to people about, if we've got a microorganism here, how not to move it over here. So let's stop that transmission of moving microorganisms. So you become certified in infection control after 2 years of working in the field. So I call myself board certified in infection control. I did that first back in 1990. So I've got a little over 30 years of certification experience, recertify every 5 years. So just finished that up last year to maintain my certification for another 5 years. As you alluded to in terms of your listeners, I've worked in acute care as an infection control practitioner. I've worked in non-acute care. My last site before I came to Diversey, we did rehabilitative medicine. We did geriatric medicine. We did palliation, where we looked after people to end of life. And we did mental health or behavioral health, as you refer to it in the United States. I've also consulted with almost anywhere where you can transmit infections. So I've lectured to teachers, students, and custodial staff. I did a lecture for Boy Scouts once on disease transmission. I've worked with industry, and I now currently work with industry full time. I did a presentation to funeral directors. Anywhere where you can move an organism around and someone might get sick, I seem to have had my finger in that.
That's a really interesting background, especially when you talk about funeral homes. That's the last place I would have really thought about it, but it makes perfect sense. I mean, really. So that's interesting. I mean, I don't know that we've had anybody on the show with such a broad experience, especially in terms of different settings. You mentioned teachers, and again, I can see where this just comes in so strong for the world we're living in today, because you can relate to different audiences. And you talked about your theater background, which I thought, boy, that is really interesting. And I know how much that comes into play when you're trying to educate people. And you're clearly somebody who is focused on educating, not just because you told me that, but because of the work that you've put out online. You're actively sharing information, trying to get people interested in these conversations. And I think having that theater background probably makes you very comfortable in front of those audiences. And you think a lot about how you're communicating, not only verbally, but non-verbally. And that's all very important to getting a message across. So that makes you a perfect fit for our show. And I want to dive into your article a little bit that really drew our attention, which was around considerations for primary care offices. Because again, we haven't really talked about that setting in healthcare. And I think a lot of times people go, well, I'm pretty much well by now. I've gotten out of the hospital. Everything's going gravy. I'm just going for routine, checks, etc. But I know, just having visited my primary care physician's office, and early on in the pandemic, they wanted to do everything virtually. And then they kind of returned to more of an in-person, with certain requirements, the way that they spaced out in the lobby or the waiting area. For a while, you had to wait into your vehicle until they came and got you. Like all of these things that really they were not used to operationally. I mean, the operational impact on adjusting to this environment in physicians' offices, just as a consumer, was clearly incredibly disruptive.
100% so. Just the fact that you had to really think to go to the grocery store because you had to have a mask at the start of the pandemic. And here where I sit in Ontario, Canada, I still have to have a mask on to go to the grocery store. That's mandated by my province, not just my local area. So there was a lot of changes that we saw from that. And there's a lot of stuff that started to happen because of the pandemic that I'm sort of going, yeah, we always should have been doing that. And there's been a lot of discussion as to what we want to move forward with. And I tried to talk about that in the article on LinkedIn. I've done a webinar on this again of what we need to look at in that primary care physician's office. Because you may be going in with a sprained ankle in the good old days, let's say pre-2020. You're going in to see your physician because you turned your ankle. It's purple. It's ugly looking. You can't weight bear. You got a bit of a cough and a sneeze. And you sit down next to someone who just came out of hospital after their bone marrow transplant. And across the way from you is a young infant who hasn't received his immunization schedule yet. They're there for their next series of shots. So you've got this little mixing pot in the physician's office where you have a lot of susceptible hosts. Again, I'm always back to this chain of transmission. You've got a susceptible host. You got a bunch of people that are carrying various infectious agents that could get spread. We are the living, walking reservoir where these bugs hang out. You, with your cough, runny nose, now have a portal of exit where this bug can get out. Move. If you sneeze or push yourself out of the chair and the bone marrow transplant patient uses that chair right after you, they've now got bugs on their hand. The mode of transmission was touching a surface. They wipe their nose, eyes, or mouth, their portal of entry. They're going to get sick from your bug because they're a susceptible host. So in my talks and moving forward, we got a little over the top in terms of disinfecting everything under the sun. People thought because of COVID, I need to wipe. And I kept sitting here going, there's a lot of silly stuff going on. And we've started to refer to it as hygiene theater, or the theater of clean, where people are doing stuff because it really looked good. And there's unfortunately manufacturers out there that were trying to sell stuff on people's fear. And that's where I've always tried to pull back going, okay, you don't need this or you need this or whatever. So even when I'm working with schools or if I'm working with a physician's office, I will pull them back from the precipice of, you don't need to really fumigate the entire room after one person's gone into it. What you need to look at are what are the surfaces that are the highest risk of transmission, what we call high touch surfaces. And then the general education that my children were well versed in because they had me as a father is we never touch our nose, our eyes, or our mouth with hands that have not been cleaned. So my practice as a lab technologist served me so well going into a hospital setting because I could not eat or drink at work in a hospital laboratory. As soon as I put my white lab coat on to protect my clothing, when I sat down at my microbiology bench, I could not touch my face. That was taught to me through college. To the point, at college, if I walked into the lab in the afternoon, because we had a 3-hour lab every afternoon to learn what we were doing, if I was chewing gum, I got kicked out. And you had to make up that lab on your own time. If I walked in with a water bottle, which actually we didn't have back in 1978 when I was at college, but if you walked in drinking, you were kicked out for the day. You do not eat or drink, full stop. So when I actually got into infection prevention and could eat at my desk, it was a novelty to me to be able to eat at work without having to take off my lab coat, wash my hands, and go to the cafeteria. So I was also of an era where I didn't use a lot of gloves because I knew when to wash my hands. So if you consider the different specimens I hand out as a lab technologist, you name a body fluid, I have probably had it on my hand or on a swab in front of me, or I've grown the microorganisms that can make people sick. But my training taught me I would not get sick. I would work in such a manner all the time what we now call standard precautions or routine practices. You treat everything as though it's going to kill you, especially in the laboratory, that it has served me well. I generally don't get a lot of colds because I'm not touching surfaces and touching my nose, mouth, eyes, or mouth. And with Diversey, 2019, I was 140 nights away from home, most of that using airplanes and trains to get around. And yeah, I got a cold a year kind of a thing because there's some things that are just going to get you. But there's a lot of things that we saw that I considered overkill that I want to pull people back. And that's what the article was about. Let's focus on what are the high touch surfaces. Let's focus on what you may have done with that customer patient that has come to you. So that's where I hope that information got out to people, that let's pull it back a little bit. But at the same time, we have to have a good awareness of what we are using to achieve some of this killing and disinfection.
So, Jim, let's say we're each moving forward post-COVID guardians of our own safety. If we were to walk into a physician's office then, what should we be looking for to get maybe what you might call a sense of satisfaction or a sense of comfort? What would we look for to build confidence and say that this physician's office is really practicing the standard, if you will? But can you give us some tangible examples? For example, you were talking about wiping down or disinfecting frequently touched surfaces. What else might we want to see? Certainly, we're going to look for hand sanitizer dispensers. That's going to give us a comfort level. I know sometimes when I'm at a restaurant, I'll see inside the bathroom, I'll see a sign and there's a checklist and there's a date and a set of initials of someone when they last cleaned the bathroom. It gives me a sense of comfort. So post-COVID, and maybe even compared to pre-COVID, what now do we want to see so we can kind of exhale and say this physician's office really is on the ball, and I can take comfort in knowing that the risk of me getting infected or infecting someone else while I'm here to see the physician, what would make me comfortable? Other than what I listed, what else do you think of that we should be seeing as a change moving forward?
So part of my background is in 2003, I was a frontline infection control practitioner during SARS, which hit Toronto, Ontario, Canada hard. And I was 2.5 hours up the road. And we learned a bunch of stuff from SARS. And this is SARS-CoV-1, right? We now have SARS-CoV-2, the mutation or the new version of it that came out. What we learned is if you are unwell and you're going to the physician's office, all physician's offices, definitely in Ontario, and I think it's spread across Canada, every time I walked into a physician's office, a dentist's office, my optometrist, there was a little sign that said, if you have a new cough or fever, put on a mask and let us know. And that was the first thing. Now, we all are doing this now. And as we move out of the pandemic and SARS-CoV-2 becomes more of a seasonal kind of cold virus that will still get people, we'll probably have an annual immunization that comes up for it just to keep our boosters up like we do with the flu shot. But I would expect to see, if you are unwell, let us know. And I think you're also going to see some spacing within the waiting rooms. And as you stated, Larry, hand sanitizer as I walk in with an emphasis of, hey, welcome to our office, clean your hands. Let's start there. Let's know that you've come in with clean hands.
And what if the physician, when treating you, and maybe you can also discuss a little bit about the different patient populations visiting different types of doctors, a pediatrician versus a urologist, maybe versus an OBGYN. What in the past, I myself, and I know the audience listening, would look for gloves. If the physician was wearing gloves, we felt more comfortable. If he wasn't, we weren't sure what to do. Would we ask him to put on gloves before he touched us, or examined us, or were we overstepping? Do you feel that the issue of masks now with COVID is as important as gloves? And if the physician isn't wearing masks or gloves, should we ask them to?
Whoa, good question. So gloves are not a panacea for a lot of things. If anything, I've spent my career trying to tell people when to take them off. And I had a friend, I don't know how old people are that listen to this, but my friend referred to gloves as flypaper, sticky. So if you touch something with gloves on, they tend to pick up more than you would if you had just your own natural skin with its oils on it. So I have no trouble. If I go into my doctor saying, I think I've got a touch of pneumonia, I've got a mask on, and they tap on my chest to see if they can hear fluid in my abdominal cavity, I'm fine if they don't have gloves on to do that.
As long as they wash their hands when they came in the room?
Exactly. So that's more the important thing. I used to try to educate medical students back in let's say the early 90s, that when you walk, this is medical students, because at Queen's University, we used to see the medical students about 6 weeks into their training to talk to them about infection control. We did it very early. And my rap with them is it really establishes something for your patient if you walk in rubbing the hand sanitizer on your hands, because this is when it was still brand new. But if you walk into the room to examine a patient saying, oh, sorry, please pardon the smell of the alcohol, I'm just getting my hands as clean as possible before I examine you, it sets a rapport. Now, alcohol hand sanitizer became very common. I actually stopped a physician once in emergency. I was in with a friend who needed to be examined. They came in without rubbing their hands. And I said, excuse me, would you mind sanitizing your hands? And you got the, oh, I just did it outside the room. And I'm thinking, okay, that's my little BS flag I'm going to throw here. I don't think you just did it outside the door. Do it in front of me. I didn't make a point of it.
And you touched a doorknob. It doesn't even matter. That's one of the most effective methods of transmission.
Yeah, one of the more commonly high-touch surfaces. So, the glove used, the mask on. If I have a cough and a fever with my mask on, he really doesn't need to have a mask on. Whereas if he's not sure, or if it's seasonally, there's a lot of stuff going on out in the community, which we can get that information from our public health people, he probably wants to have a mask on to protect himself from me, because nobody likes getting sick with things like that. I think what we want to see, and it will vary. So if I go in to talk to my doctor about a mental health issue, I'm feeling a little down, I want to talk to someone about it. Can you prescribe a counselor for me? Because here in Canada, I can write that off then through my insurance. And I sit in the chair and talk to him and leave. At most, they may want to wipe the arms of the chair that I sat in. I'm not too worried about where my butt touched the bottom of the chair. But where I actually had my hands on the chair, that's sort of a high touch surface. Let's do that afterwards. You don't need to do the exam table if I didn't sit on it. You don't need to do the otoscope and the all the different scopes that are hanging up there on the wall. You didn't take my blood pressure. That doesn't need to be wiped. Whereas if I went in for a prostate exam, I'm talking to a bunch of guys here. I have to assume the position on the exam table. That piece of paper that they pulled down really doesn't mean anything to me, other than you're trying to catch any waste that might come off of me during the examination, whatever it may be.
But aren't they also giving you that sense of satisfaction? In other words, isn't there a cosmetic element to that builds confidence that if by the converse they didn't give you a new piece of paper covering whatever that napkin is that you then rest against? I always feel more comfortable in an office where there's a new strip of that paper for me and each patient. Conversely, I get a little concerned if there isn't a new strip of that paper.
But you have absolutely no idea what happened from the previous patient, what went on that piece of paper. And if it was just torn off and a new piece of paper put down, and the actual bed that you're lying on is never wiped off, that's where I have the more concern. I would rather go in to see my disinfectant still evaporating off, depending on the contact time of the disinfectant. I know if I see my product sitting over on the shelf, that as long as that surface stayed wet for 1 minute, that's our contact time on our product, that will kill 99.9999 6 log of the microorganisms that might be present on that bench. So I want to see, personally speaking, a little bit of fluid on there that they may have to dry after the 1 minute. Then the paper can go down as a reminder. Because I think what the paper does in my new world...
Well, the paper doesn't cover the whole surface either,
exactly.
Right? It's coming down the middle of the... Exactly.
And I remember having this conversation in 2003 in the middle of SARS, when somebody said to me, what the heck does this piece of paper do? Because it's actually reasonably flimsy. So what the paper does do... It reminds the person who's going to clean the room after I leave, be me in there to see my OBGYN as a female, be me in there for my child to be examined. The paper gets crinkled, so the person who's going to come in to turn the room over after I'm done to get rid of my gown knows somebody sat on the bench, on the exam table.
It's a physical indicator.
Exactly.
It's a physical indicator of cleanliness. That's genius. I never even would have thought of that.
So that's sort of that verification that this surface needs to be cleaned. Now, at the same time, I have a statement that I use in my presentation, especially for healthcare workers, that it is everyone's job to disinfect. It's not everyone's job to disinfect everything every time. And a lot of times I get this look, and I have heard people say to me, that is below my training to clean. And I'm not going to use a specific training here, but very seldom especially if you have an office assistant that is going to come in and clean the room. Why would I clean something? I've got someone that I'm paying, minimum wage plus 15% to come in and do all this cleaning. I'm making my gazillion dollars a year as a physician or as an RN. Why am I going to grab a wipe? Well, my thing is, if you've used it or you've touched it, disinfect it. This is my new catchphrase that I'm using with healthcare workers. If you've used it or touched it, disinfect it. So if you come in to see me, Larry, and I'm going to look in your ears and shine my light down your mouth and take a peek up your nose with my little handheld thing on the wall there, I've used it. I'm going to grab a disinfectant wipe before I put it back up and wipe it off and stick it up on the shelf. Now, the exam table is a bit different. That's going to take more time. I got patients to see. So my office admin will come in, see that the paper's crinkled, change that, get rid of the linen that might have been used as my gown, and then do the disinfecting of those high-touch surfaces.
So, Jim, this brings up a really good point, and let's not spend too much time on it because we have a couple other important things to get to, but the differences between what's being done in Canada and in the U.S., and maybe I'm missing it, but when I go to my primary care physician or ophthalmologist or an ENT physician just for a general exam, I don't see any administrator coming in and wiping down anything. There's that paper and cover on the couch, if you will, that I sit on, and when the next patient comes in, it is what it is. Am I missing something?
No, you're stating what is normal practice up until this day. And what I'm trying to do through my article and my presentations is we need to have a much higher visible commitment to infection prevention and control. Now, for someone who is a bit of a fever with no, what I like to call soiling of the environment. So if someone comes in that's not coughing, sneezing, snorting, leaking, you don't have to clean as many surfaces as an examination where you may contact mucous membranes. Because our mucous membranes, which is things like your eyes, your nose, your mouth, in guys, it's your rectum and urethra. In women, it's the vagina. The mucous membranes have a lot of bacteria on them, to put it nicely. And the bacteria are protective to us. That's why they're there. That's why we have bacteria in our mouth. That's why we have bacteria in the vagina, because it keeps the bad bugs out. It's a competition kind of thing. But I really don't want to experience someone else's microflora on a surface. At the same time, as I leave the exam room, someone should say to me, here's our hand sanitizer, have a good trip home, so that I can clean my hands in case something was missed. And this gets into a little bit of cleaning and disinfection is not as straightforward as most people would like to believe. We have another statement in my company, and I have a lot of cliche kind of statements, but just because you use a disinfectant doesn't mean you've disinfected. And I think you can grasp that there's a lot of disinfectants that have a wet time, so a contact time. So if you've got a disinfectant that you're using that says keep the surface wet for 10 minutes or 4 minutes, that's to kill the bacteria that are on the surface, to get to that claim of disinfection. If you've got a product that has a lot of alcohol or a solvent in it to make it work faster, it may only stay wet for 45 seconds. And when you look at the label, it says keep wet for 3 minutes. So you haven't really done the full job.
Why does the label then not say, if it says, let's say, a 3 minute with a quat or something for 3 minutes, if the drying time is more rapid than the contact time, that means the product can't be effective. How could we have the label of a product saying something is effective when it becomes dry prior to it being effective? Does that make sense?
Yeah, what the language states is, and I've seen this on other products, is keep the surfaces wet for 10 minutes. Keep the surface wet for 4 minutes.
Wet with what? The disinfectant or water? It would have to be the disinfectant. But
Correct.
If the disinfectant evaporates before 10 minutes, which is common, there seems to be a conflict there.
Yeah, you've done a little bit of cleaning, is what I refer to it as. And I still see this. And this is a problem not only in physicians' offices. Unfortunately, a lot of long-term care facilities, especially if they're trying to turn a profit, will use a cheap product. And the way I give my analogy to this is the faster the contact time, so the shorter that you have to keep it wet, the more expensive the product. So a 10-minute quat is pennies a gallon, literally. A 1 minute contact time product, you're going to be paying a little bit more, especially if it's a pre-wetted wipe. So when I go to my physician's office and I saw the 1 minute product on the thing, she's probably paying 11, 12 cents a wipe, just to make it up off the top of my head. Whereas if she had a dilution station, can make up a bucket, dip a cloth in it and wipe down the bed, that's costing her a couple of pennies a gallon. But she's not going to keep it wet. She's not doing an effective job. I'm always trying to tell people that if you're going to use a disinfectant, make sure you read the label. And this is where we can segue into store-bought products and what are they actually killing. I don't know if you've been noticing in the media and the literature that we didn't have a cold season last year because everybody was staying home when they were sick. They were all wearing masks. We're wiping everything down under the sun. A lot of manufacturers are coming out saying, hey, my product kills COVID in 15 seconds. But if you look at the label, there's a lot of other viruses that make us sick that it won't kill in 15 seconds or even in 4 minutes. A lot of your store bots that say 99.9% of cold and flu viruses do not kill rhinovirus, which causes 30 to 50% of colds. And it doesn't kill the vomiting and diarrhea virus that we call norovirus. It doesn't touch them. So you may have somebody sick at home. You run out and buy your store-bought brand that kills 99.9% of cold and flu viruses, and your partner's got stomach flu. Well, this must be great. Well, that doesn't get covered by this product. And that's where I'm doing a lot of education also to people is you got to know what your disinfectant kills, how to use it, how long it has to stay wet. And the dilutable quats, something I talk about all the time, that is if you put a cotton cloth, an old face cloth, into a quat disinfectant, all of that active agent binds to the cloth. And you don't put anything on the surface except water. It's an anion cation reaction between the two. It's well recognized, but it's the education we have to get out to people that if you're using a disinfectant, know its limitations.
So as we were kind of teeing up for a couple of minutes, getting to know each other, we talked a little bit about the reason that the name of this podcast is Transmission Control. And I know we've just got a few minutes left here, but I think you did a really nice job of talking about, cleaning appropriately and a lot of those portals of entry and how to protect yourself related to that. But there's a common term called the chain of infection. And you said you like the term chain of transmission better. And what's interesting is Larry and I really, that resonated with us when you said that because we've been focusing on the concept of transmission much more closely than infection because infection is the end result, but transmission's what's happening. It just may not always become evident that a transmission occurred. And so we've always seen that as that extra level of attention to detail. And, it's preventive. It's very much a preventive kind of concept. If we prevent transmission, then the likelihood of infection is zero. But then you introduced this idea of the chain of transmission. And so I really want to hear you talk about that concept in your own terms.
Yeah, you summarized it really well, Justin, I think, in that I want to stop the movement of microorganisms. Yes, if I do that properly, someone should not get infected and sick. But it's the actual movement of microorganisms. And this gets back to the degree of my susceptible host. I could come in contact with some of your organisms through the chain of transmission, but I'm not a susceptible host. So I'll pick up your bug and it's not going to make me sick. But then I could come in contact with another susceptible host who could get sick from your bug. I act as the intermediary. I'm a reservoir as I move it through the mode of transmission to a new susceptible host. So it's not that I want to live in a sterile world. We do have an immune system that keeps us safe from a lot of different things. We know now what we saw with COVID is that we really all should try to keep ourselves healthy as best we can, eat a regular balanced diet, blah, 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 all that kind of stuff, because that limits down our susceptible host. And COVID showed us, unfortunately, who were the weak in our population worldwide.
But we had been talking about those demographics for 30 years.
Exactly. So to me, my standard infection prevention and control is the young and the old. You got a kid in a neonatal intensive care unit up in the NICU. They're the most susceptible young person you can find. And then you've got an elderly person at 96. They're very susceptible to infection because their immune system has broken down. It wears out after a while, to put it very mildly. I actually do a full 40-minute presentation on why the elderly get sick to try to let care providers know why we have a lot of precautions in place around working with the elderly. What we saw in long-term care with COVID was much more, we weren't prepared to have a whole bunch of sick people in our long-term care facility. We didn't have a lot of masks, a lot of personal protective equipment. The virus was discussed, originally we thought it was being spread by this droplet spread, right? Very close, face to face, within 6 feet, 2 meters of other people. Fairly large droplet. In my day, we used to define droplet precautions as particle sizes over 5 microns because they felt that they dropped off because of the size. We also had airborne precautions for particles smaller than 5 microns. But this virus has allowed us to do the research on that. And the term we're using now is spread by the air. And we're trying to get away from droplet airborne because we get into these face-to-face arguments as to what is droplet, what is airborne. Because we know there are certain circumstances where this virus can move through the air. If we have any kind of stagnant air with a lot of people in it, it's going to go a lot farther than 6 feet. If we have air in a restaurant where there's a fan behind me while I'm coughing, it's going to move my spit from coughing a lot farther than 6 feet. And we got evidence of that. There's a great study done in China on that, where it was a restaurant and who got sick from somebody who didn't, and they were asymptomatic. We've got studies now on how much I have spit sitting here in front of my computer, talking loud to you guys so that it picks up well, that there's a lot of particles that have come out. I had to shut my doors of my sunroom here, so I'm sitting in stagnant air. And I probably got a lot of particles that have floated more than 6 feet away from me. And so, a lot of the precautions we're trying to put in place that people seem to buck up against are, we want you to put a mask on because this virus is really unusual in that you can carry it in your mouth as a susceptible host. You could have it transmitted to you and not look sick. But you're then that mode of transmission. You're the reservoir because you've got it in your respiratory tract. We know you're going to excrete it when you talk, laugh, sing, cheer. So put a mask on. So you just catch it as close as you can. That's the primary basis for doing it.
So this is a little controversial, and we don't have time to really get too much into the differences between contact precautions, droplet precautions, and airborne precautions. You were saying this novel coronavirus can be transmitted both by respiratory droplets and airborne, and then you said we should all wear a mask. Maybe we need to clarify what type of mask you're talking about so that the listeners can get an understanding of specifically the differences between droplet precautions and airborne precautions, specifically vis-a-vis the type of mask you're recommending to wear to prevent the transmission.
So you're right, this is controversial, and I'm probably going out on a limb to say it. Personally speaking, not representing anybody, as long as I've got something covering my nose and mouth, I'm a lot better off than having nothing on in terms of transmitting. To protect myself, if I'm a healthcare worker working with someone who has COVID or other viral respiratory illnesses, there's controversy on that. In Canada, we are still calling this contact droplet. If I'm working with a patient, I will wear a surgical mask with an attached visor to protect my eyes, or a surgical mask, which has that fluid resistance on the outside of it, and goggles, as long as I'm not performing an aerosol generating procedure where I'm actually taking the particles in the respiratory tract and throwing them all over. Then I go to a N95 respirator.
Isn't exhaling doing exactly that, producing aerosols?
To a degree. What we have found is it really does vary. And a lot of the studies that I'm starting to see is that there's a lot more viral particles in the large droplets than there are in the small droplets. So yes, you might be excreting virus. What we have never shown well is how infectious the aerosol particles are compared to a droplet particle. And this is being done. Again, I keep trying to remind people, we're only 18 months into this. We're still learning a ton of stuff about the actual virus transmission. The vaccines came along a lot quicker. Again, that's a whole other 40-minute conversation you and I could have on the development of the vaccines, the safety of the vaccines, why they came so quickly. Because my standard line is you throw enough money at something, you can get things done really quick. We did that with the vaccine development. We put billions of dollars into it. Whereas influenza, it kills a few people every year. We got a vaccine that sort of works. Nobody does a ton of research on it. And I think if nothing else, our flu vaccines will get better because of what we learned from the COVID vaccines by introducing new technologies and stuff. So there's, like you said, there's so much controversy on what is infectious and how it's spread. WHO in Canada went with surgical mask, eye protection, and contact precautions, cover your clothing. Whereas the United States went with its airborne transmission. You want an N95 respirator on if the patient is unwell at all times. And if you're going to do the aerosol generating procedure, like if you're going to have to put a tube down their lungs to take a look, do an endoscopy on them, or if you're going to give them medications that's aerosolized or do CPR or intubate them, that's an aerosol generating procedure. You then want to go into a room where the air can't escape the room. The air is drawn into the room and is
negative room pressure. And you're talking about for COVID-19 or for other respiratory pathogens as well?
Well, this is where it's getting very interesting. We learned in Canada after SARS that there are certain aerosol generating procedures that you should have an N95 respirator on full stop if you're working on someone with a cough or fever. We didn't care what the pathogen was. If they were unwell and you're doing an aerosol generating procedure, you should have an N95 respirator on. So if I was in a car accident, they took my temperature and my wife says, oh, Jim's suffering from influenza and they needed to intubate me. I have a cough, fever. They should have had an N95 respirator on to intubate me because that is an aerosol generating procedure in our definition in Canada. What happened with SARS-CoV-2 is everyone started to classify what is an aerosol generating procedure all the time. So your gastroenterologists that were doing colonoscopies started calling that an aerosol generating procedure because of the gas that we put in to inflate the colon so they can see what's going on gets passed. And that could be aerosol generating, which that's not an aerosol generating procedure, really, in my humble opinion. The gastroenterologists listening in will argue with me. Dentistry classified almost anything that they do with their equipment as being an aerosol generating procedure. So dentists had to get the rooms under negative pressure. They had to get an N95 respirator that nobody's been fit tested for. Now I'm seeing, and this is what drives me crazy as an infection control practitioner, is we're trying to change what we do with patients based on a culture. So if you're going to go in and be intubated and your culture is negative for COVID, they're going to wear a regular surgical mask and not worry about the air movement. Whereas if you test positive for COVID, now we're going to go N95 respirator for the intubation and have a timeout to allow the air to change. That's dangerous to me. If intubation is going to be considered an aerosol generating procedure, it is all the time. That's standard precautions. And that's where we need the evidence. There's already a paper out where they did some studies on both the intubation and extubation and said there was not a significant amount of debris liberated during the intubation and extubation. They did the study. One paper, which I'm not going to leap on, I want to see more. But we just haven't figured out how to study this. And that's the other thing is we move into 2021, 2022. We've now got the science to look at this. We've got these fluid physicists that look at this. And I've read some of their elegant studies on air movement and particle movement that we didn't have in 2003 during SARS, the original, as I like to call it. So we're going to learn a lot as we go along, Larry. To answer your question, we're going to find out if we have a patient in with a viral respiratory illness, it might have to be airborne precautions all the time.
Would that apply to influenza A?
We may find that is true. Now, to me, though, that definition of airborne precautions is everyone in the room or everyone around the person is going to get sick. And we're not seeing that still. The Delta variant, we do excrete more viruses. We seem to make more people sick around us if they're non-immunized or if they were too close to us or if we don't have our mask on. But, the number of people I could make sick with the original version of SARS-CoV-2, they kept saying was around 2.5 people will get sick from me. Now we're saying it's probably closer to 8 people I can make sick.
Because it's more transmissible.
Right.
That strain.
But that's partly, more transmissible. I had to look up what we meant by that. And basically you produce more virus particles and it does it quicker. It's much more efficient. And this gets back to my whole thing of we need everybody possible immunized so that we don't have walking Petri plates to allow this virus to mutate again. Because every time it can get in and make someone sick, it's going to take that opportunity to try to mutate itself. Because if it mutates to not an effective pathogen, it doesn't survive. It wants to mutate to what we saw from Alpha, the original version, to Delta, where it's very, very efficient at getting in. It penetrates much quicker. It reproduces itself at a magnitude of 1,000 times quicker or a higher number of particles. And if we keep allowing the Delta variant to do that by making people sick, it's going to mutate again. And, we've already got the MU version of it coming out that we're still now just taking a look at. Well, how is it mutated now? What's it doing to get better? Because viruses want to do that. They want to become the best killing machine known to man so it can keep reproducing itself. If it just gives you a bit of a fever and it goes away and you don't make anybody else sick, it's not a very effective pathogen. So that's what we're up against with this for sure.
All right. Well, Jim, great interview. Lots of good information in there, especially as it just, the thing I loved about physicians' offices is it kind of takes that general public day-to-day connection to all of this and translates it between, somebody who's just a general citizen, maybe has no experience in all of this, watches the news every single day, is concerned about how to move through healthcare, or maybe he's on the other side and could care less and thinks this is all just a media hoax, right? And so, I think a lot of people end up somewhere in the middle in the general public, but I think infection control practitioners obviously taking this extremely seriously, putting a strain not only on their profession, but their day-to-day work environment. And so I just thought, what a great way to really reach out into the community and really, kind of paint this picture. And especially, honestly, one of the biggest takeaways for me was just the whole process orientation of the paper in the physician's office. That was just like such an interesting takeaway for me. So I want to thank you so much for coming on the show today. And I definitely think there's an opportunity for us to have an episode to talk about the vaccine and, the rollout. I think that would be a very interesting topic for us. Obviously, no time for that today, but.
And ultraviolet disinfection.
Yeah. And ultraviolet as well. We didn't get a chance to get to that, but Jim, great job. Thanks so much for coming on the show.
Not a problem. It's been a blast, and please have me back again. I'd love to talk some more.
That was Jim Gauthier, MLT CIC, Senior Clinical Advisor of Infection Prevention at Diversey. And Larry, I meant it when I said to Jim as we were wrapping up that one of the most interesting takeaways, and it seems so minor because it was, pretty in-depth conversation with Jim today, not only about primary care physicians' offices, but also just in general related to the pandemic and portals of entry, which I think everybody is familiar with. But I never really thought about physical indicators in this same way around a process that would happen in physicians' offices that would be an indicator that another process had been done that was a human process. Most of the time when I've been talking about physical indicators in the surgical space, as you know, Larry, it's really been much more around physical indicators that a mechanical process had been undergone. But this is more of a manual process, cleaning, and just the paper on the exam tables is an indicator that something happened in between one patient and another. At the same time, it still doesn't tell you that it had the right exposure time, that it was cleaned properly. It just tells you whether or not it was attended to on some level. But that was just so interesting to me. I never would have expected that.
Right. Another physical indicator that comes to mind is that a physician has two hands, which means he has two gloves. So a quality auditor might come in at the end of the day and say if the physician saw 12 patients in that room, the auditor should probably find 24 gloves in the trash can, and then that would confirm for us that the physician was wearing a new pair of gloves for each patient. If the number of gloves is not twice as much as the number of patients, well, this may say something.
Yeah, big concern there. All right, well, great job, Jim. And I do want to let everybody know to go find him on LinkedIn and be able to take a look at his educational material and information, especially the particular article that we talked about today. That was, if you find Jim, and I'm going to spell his last name for everybody, it's Gauthier. If you find him on LinkedIn, you'll be able to find the physician's office's article that he posted up there. That's going to do it for this week's show. As a reminder, you can help support Transmission Control on Apple, Amazon, or Google Podcasts, as well as Stitcher, iHeartRadio, Spotify, or just search for Transmission Control on your favorite podcast application. You can also access bonus content for certain episodes by downloading our smartphone app for iPhone and Android. We'd certainly appreciate a rating and a review because your feedback is important to the show. And on behalf of Larry and myself, thank you for listening to this week's episode of Transmission Control.